Morning, everyone. I hope you all have enjoyed your dinner. So, thank you for joining us tonight. So this webinar is organized by my webcast Sendirian Berhad. I'm Dr. Ng, and together with Stephen, we are the moderators for tonight's webinar. So once again, we are happy to have Dr. Chen Hui Cheng as the speaker for this webinar. So in last week, she had delivered a revision on anesthesia monitoring, and for tonight, she will be presenting her talk, which is related to anesthesia complications. So for those who are interested in last week's webinar on anesthesia monitoring, you may contact us to get the link access to view the recording. So later on, Dr. Chen will also address some of the questions we have collected via the attendance form last week. So okay, right now without further ado, these are the housekeeping notes from us. Please remain on mute throughout the webinar. If you are facing any technical problems or have any questions, you may post on the chat box and we will attend to you shortly. And secondly, the QR code and link to submit the attendance form will be provided at the end of the webinar, and e-certificate will be issued to those who have submit their attendance form and also register veterinarian in Malaysia. And the certificate will be sent within 14 working days. Okay, so this is the agenda for tonight's. First of all, we will start off with introduction and housekeeping notes from us, followed by presentations by Dr. Chen Hui Cheng. And after that will be a short and brief product introduction. Then we'll be continue with a 10 minutes Q&A sessions. And finally, the webinar ends, then the link and QR code to submit attendance form will be provided. Okay, so here is some introductions about our speaker, Associate Professor Dr. Chen Hui Cheng. So, Dr. Chen is from Department of Companion Animal Medicine and Surgery in the Faculty of Veterinary Medicine (UPM). So, her expertise is in the field of veterinary anesthesia and analgesia. So, she obtained her Doctor of Veterinary Medicine in 1996 and Master of Veterinary Medicine in 1997 at UPM. So after that, she obtained her doctorate in veterinary science in 2005 at the University of Guelph, Canada. So she is a really experienced educator as well as an experienced clinicians with more than 40 publications published in scientific journals. So now let us welcome Dr. Chen to present her talk with a title Anesthesia Complications What to Do. Dr. Chen, are you ready? And maybe I should stop.
Thank you very much, Dr. Ng, for the very kind and lengthy introduction. A very good evening, I bid to all attendees. Thank you so much for taking the Friday night to actually attend to this talk here. So it gave me a great pleasure in preparing this talk because at the same time, I'm also doing my revision. Okay. I will try my best to deliver and also address questions. Let's learn together. Um, so when we talk about anesthesia complications, um, the best practice, of course, it's still like what we also learn in medicine, which is to prevent and to minimize the risk whenever possible is always better than trying to deal with the complications. So in talking on this, so perhaps I will just actually like take the beginning of the first few slides to review what are some causes of mortality and also like what could be the cause or the source of the complication, so that when we review that, perhaps then we can check back on ourselves and actually try to minimize the risk. According to one study that is in UK, again, it's actually been the longest time, but still, that is based on the reference point that many guides actually kind of like talk about. We see that actually the majority cause of actually like anesthetic mortality, it really actually like center around the complications related to the cardiorespiratory system. Okay. The other also, the next would be actually like neurological, although we see here actually like 20% of those cases that actually like it's not able to actually like diagnose what it is. So really able to actually like monitor and detect, like any difficulty arising in these two cardiovascular system is very important, because that's where then we can immediately deal and actually save the patients. Where else things related to the renal and the liver probably will not see that. And maybe if let's say, like it cross over the critical time, if we can then to actually like try to address that, but then able to save the patient in terms of actually like elevating the cardiorespiratory difficulty, it's really actually very important. So in terms of actually like cardiovascular causes, some of the causes that's been listed, or the problems that could be identified, include things like hypovolemia. That's actually like could be related to actually like usually related to the volume itself. Either it's not addressed, or it is actually from the hemorrhage intraoperatively. You may also have actually like a problem related to the heart, and it could be also actually like respiratory, basically again causing the myocardial hypoxia. Um, and of course, actually, like a certain anesthetic perhaps may have a less safety margin. And of course, if actually like there is like a overdose, that can precipitate to cardiovascular collapse as well. Similar with respiratory as well. Other than that, for the respiratory system, like if we fail in the endotracheal intubation, or actually causing trauma to the respiratory tract, or actually like not able to address on the adequate ventilation, or in fact actually like we're not able to give adequate oxygenation, that can precipitate on to complications. Okay, we now go on to actually like review on some common causes of complications. Um, in this case here, like human would be actually number one that we actually check on. One of it is actually like checking on ourselves, like whether we do actually like at least check on the patients. Um, that's actually like talking about the pre-anesthetic screening. Um, I mean, like speaking on this actually like terms of anesthetic screening, I do actually like get sometimes I mean, like it pick on me when actually like students, when you talk anesthetic screening, means actually like taking blood and doing anesthetic screen. So anesthetic screen is not just doing blood; it is actually like in fact up to the point of actually doing a proper history, and also at least like physical examination to make sure that the patient's status is actually like can be examined. I think I used to actually like all students who have come to my lecture in DVM3, things that I always emphasize. If your clinic is planning on actually doing elective procedures of your usual routine spay and castration on a routine recipe that you have developed, you really want to make sure that your animal definitely is in ESA class 1, meaning healthy otherwise, and so that they can go through your standard protocol that you're using. But if it's actually like have some underlying problem that you have identified, so that you won't get caught off guard, and that's actually very important. Um, then the other is actually on the familiarity with the anesthetic machine. If you are actually like using, or the drugs that is being used, is very important. Um, and that's where we also can see, if let's say like just like myself working in a hospital, where we have actually like all different types of agents. Even anesthetic machines have so many, and so if the particular anesthetist, the anesthetist here meaning actually like can be actually like the student or even the staff, veterinary nurse, for example. If they're not familiar, then that is actually like it's a big thing. Even actually like it also recently happened to myself when I actually like need to handle a anesthesia in a new environment, whereby as the first morning itself actually like get introduced to the new machine. Although in general we know actually like what are the common parts of it, but actually when we have not been trained on the use of the machine, So, like the inertial part can be a bit chaotic, and then we may actually like tend to make some mistake if we are not familiar with the anesthetic machine. So if you do get actually like machine, or if you're in your clinic, or if you have a new staff that join you, for sure, it's actually like training to get familiarized with actually how it's being used is very important. Cause the common parts is always there, but able to actually like use it is and be familiar with every parts of it, especially when there is emergency, knowing where is the pop off, where is the bag, how do you give emergency oxygen, all those are so very important. Drugs for sure, yes. And actually like knowing what is the any potential side effects and contraindication of certain drugs is so very important. And some vets may have actually like say, oh, we have actually like so little or not many choice of actually like drugs. For me, I think I'm a very conservative and very safe person. We can still actually like do so many things with whatever we have now in Malaysia actually, which is actually like not too bad, and we can really actually get around it by actually knowing the different options and how we can actually like uh, play around with the doses and how we're going to use it and mix and match on that. That's actually like very important. So if we have been introduced a new agent, or somebody were brought in, so I think it's very important that we do get trained on the new drugs that will be actually introduced, if we ever. Okay. um hey. uh Okay, yeah. Drug, like labeling of actually like drugs, whether like we given the right drugs, dosages, route, and concentration, for sure, very important. So for this here, if you want to minimize the complication, the clinic or your own practice probably would have actually like a certain SOP of like how to minimize that, like mistake made from here. Concentration is very important. I mean, like there are drugs that actually come in slightly different concentration, and with anesthetic, when you actually calculate wrong, uh, two times the volume, two times the dose given sometimes can be fatal, depending on what we are talking about. Some drugs actually like we may actually like accidentally give 10 times, and so actually like we can be very lucky if, let's say, the drugs have a wide margin of safety. So very important as well, you have your own SOP. So one of the things that actually like to minimize that is, like if your practice has always been ordering the same, brand or that concentration, and whoever's doing the purchasing, if there's actually a sudden change of that, it's really important to actually like trickle down and inform everybody, because the other way in terms of concentration, how you want to deal with that. Because I think most actually like practice probably would come up with charts that is very easy for you to actually like look up. For example, in terms of actually getting a chart of actually like what's the body weight of the animal, and therefore what's the volume of certain drugs based on the recipe that you are used to, if you do have that recipe for your standard ASA class 1 routine elective procedures. But having said that, then typically the way to actually like go is to be able to actually like really tailor your anesthetic protocol according to what the patient need, if it's out of the routine. Okay. And this part here may be actually quite challenging, if, let's say, we are not trained on here to be able to actually recognize if the physiological parameters of the patient is actually like it's not optimum, and whether able to pick it up and then actually like can recognize that is actually a potential problem. So before it further actually like deteriorate, that we want to be able to support this patient, so and that they can actually like prevent further adverse complications. Equipments. So empty oxygen tank, I think it shouldn't be happening to us, because if, let's say, we look at the clinic, usually you only have like one tank in the one OT room itself. So whoever's your assistant should be able to actually like monitoring and ensuring that you have actually like adequate oxygen to let you finish up the procedure. This one here, things related to machines. Again, to minimize this is to have like a checklist on how you actually set up your anesthetic machine. There should be a standard checklist to go through things like oxygen, adequate anesthetics. If you are using the rebreathing system, is your carbon dioxide absorber is appropriate? There is actually like one here to actually like note. Sorry, I don't have actually like the picture in here, but there is actually one product, soda lime, that actually like come in, which is, if it's not used, is white in color, and then if it's having absorbed or exhausted or absorbed the carbon dioxide, it would have turned to a purplish color. But when you let it stand, then it actually like turn back to white color. And so if the person who have just used that machine did not actually like put a note when they recognize that actually like most of the soda lime has been exhausted, you don't put a card, but to the next day somebody else come and actually use it and saw that the color have turned back to white color and thought that it is actually working. So when actually like use it, that can be a cause for actually like a complication. Okay. Yeah, breathing circuit, if you actually wrongly assembly, can be actually like causing complication. Uh, Here, some of you, I think, breathing circuit, one I can think of is actually especially the core axial. Some of you, if let's say the vein circuit is really important, if let's say the vein circuit, which is the in the middle, that the blue color inner tube, if it's have actually like broken and so on, that will cause a lot of rebreathing, and that's very bad for the patient. Uh, uh, Another one that may actually happen, although it's not as bad, if the F circuit, which is again the coaxial, if you remember, then the inner tube, which is blue color, and if there's actually like broken, it can also cause a lot of rebreathing. So what you will get is kind of like increase a lot of carbon dioxide being rebreathing to the patient. So checking on the breathing circuits itself and not and assembling it correctly is also actually like potential cause for error lah. Vaporizer problems, uh, if you have been using it and it's been working well, usually it's not a problem. It's only when you get the new one, they have not been tested on. So you probably wouldn't sure. You can't be sure. Like if let's say there's an old one, have not been actually checked, the vaporizer have not been serviced, then it probably should be sent for service so that they can recalibrate the vaporizer and check that the output is actually correct. So if it's the vaporizer problems, what I can think of, which I've also seen, is actually like, oh, one have not been checked, and then the output actually like deliver more concentration than what you usually dial. Okay. Pop-off valve can be a potential problem. And then if let's say, especially if our pop-off is not really pop-off, meaning actually like the pop-off by right, if it's working well, it's supposed to actually, like after a certain, when you reach actually like a certain pressure within the system itself, the valve should be able to pop so that it can prevent accumulation of pressure within the rebreathing system. So if there's a problem, there may be actually like uh, 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 gathering too much of pressure within the circuit, and therefore actually like cause pressure, positive pressure to the patient, and that's actually like potentially may cause barotrauma. Okay. Uh, Endotracheal tubes problem here, that's also a very common one. Either we fail in our intubation, or um, when we actually like intubate, and if let's say the tube have not been secured properly, and during the movement, whether like this tube may have actually like get dislodged or move out from the position, and instead it's been actually like like sometime wrongly just actually like re-push in, then instead of going to trachea, then it go into the esophagus. And the other one is actually like if we are not trained in actually very small patient, if we have actually like a traumatic intubation, that's actually like can be actually like injuries. The other one is I think we also actually quite familiar and have heard things like trachea rupture, when we actually like did not do the appropriate inflation of the cuff, and then we overinflate, or actually like during the movement itself, that, like patients such as small kittens, whereby their trachea can be very fragile and then actually like cause this trachea rupture. So those are potential complications. This for sure. If let's say, like any of these patients that have the pre-existing condition, that we have identified what are the risk factors and therefore plan the anesthesia appropriately, choosing the appropriate anesthetics well, that will minimize, like further risk of complication. Uh, Traumatic patients or and so on, or even actually those with a pre-existing disease, some we can try to actually like correct as much as we can before we anesthetize, but some is just not possible. So that is the inherent kind of like risk that we'll be actually like taking, and those risks, at least like if it's been identified, at least what we are more prepared for it. So we'll be looking out for those potential complications, and therefore it make it easier for us to deal with. The problem is actually like as we said before, under the part where we fail in our pre-anesthetic screening, and it could be because our own skills as well are not able to actually pick up those potential underlying disease, and that's where that actually like that precipitate complications. So this part here, I think the points we actually like have mentioned, all anesthetic drugs do have actually like adverse effects or side effects on the cardiovascular system. So to be familiar with them, example, if let's say, like we're talking about xylazine, all of us will know that actually once we give it, it does have a very marked cardiorespiratory depression. And therefore, usually, like we reserve it for really healthy patients, and then we avoid it in very young or very old patients, and so on. And then, yeah, assess patient as we mentioned before, and therefore with that, then we actually like try to pick up the best actually anesthetic, and also how to combine them, and taking note of actually like wherever possible, those drugs that will have like major cardiorespiratory depression, such as like isoflurane or even any of the inhalant agent. So it is still actually like the most practical way, and also for us to maintain anesthesia. But then to bear in mind that actually like when we are only relying solely on the inhalant, we will actually like tend to use high concentration, and we have to realize that actually like putting on very high concentration of isoflurane to enable you to actually do the surgery may precipitate the animal to be actually having myocardial depression, and so therefore the cardiac output is low and the blood pressure is low and all that. So in most healthy patients, there would have been not a problem, but when we have actually like increased risk patient with especially heart problem, that would cause problem, and further precipitate actually like complications that may occur intraoperatively. So here, the balanced anesthesia has always been actually like advocated, meaning actually like to especially use of drugs that is actually more cardio safe, such as opioid, such as benzodiazepine like your diazepam and midazolam. But then again, you need to be actually like get, in a way, be, if you have not used it before, then need to be trained, or actually like being supervised by somebody who have experience using it, and therefore carefully actually like see how you can actually like adjust the dose accordingly, and therefore how you can actually like balance up between when you're using adding on some addition, it is with the intention that you can reduce the more cardiodepressive drugs such as the isoflurane or propofol and so on. So that is actually like the way to go to manage our increased risk patients. Okay, so despite all those that we have planned and so on, as we said, that actually like most of the time is because of some underlying disease that we may not have picked up from the in our patient, and so therefore, as last week we said, it's very important then to continuously monitor the patient, and then learn how to recognize and try to support the patient early when we see that they are facing difficulty in maintaining their physiological parameters. So my next actually like half of this presentation, I will actually like put up a few of the common not normal physiologic parameters, and therefore how do we troubleshoot. So bear with me that when I'm saying this, just now when I go through, then I realize that actually perhaps some of you may not be actually like like the problem you face may be just related that you're only using one type of like injectable anesthetic, and then you are actually not using like gas machine and not using even oxygen. So like the algorithm that's actually like presented in here, it's actually like it's mainly based on actually like the guidelines that is available from the AHA guide on anesthesia, and also the AFP, which is the American Association of Feline Practitioners. So in those practice, usually the maintenance is using gas machine, so it may be actually more to that. But if that actually like does not actually like answer, like the problems that you may face, then perhaps then we can actually like learn together, and then we can discuss on that. Okay, so the first one I choose is actually like talking about bradycardia, meaning actually like the heart rate on the lower side. So if it's on dog, I actually like pick up numbers again. So easy for us to actually like like discuss. So you want to pick up a number, so I put that 60 to 80 is kind of like the wider range, because the 80 for the smaller breed dog and then 60 for the large breed dog. And then 100 for cats. Okay, so also now I actually like add in. So again, bradycardia. So it's very important though to actually remember then actually bradycardia. For me in our practice in here, because we always use anesthetic machine, we do see bradycardia a lot, and it's not actually like that emergency to us. Okay, so the following steps that's actually like continue here is based on the reference that mucous membrane is not cyanotic, okay, meaning uh, there's bradycardia, but there's no hypoxemia. But it's different if, let's say, like you see hypoxemia, and that's actually a different story. The moment you see tongue is blue, that's really an emergency, and you need to act very fast. So this scenario here is actually like no, animal tongue color still look good, okay? So immediately if you actually like see things like actually low heart rate, we probably want to actually like think about is that actually like the resting heart rate for certain patients. Maybe they have actually high vagal tones, and so therefore under GA, then they may tend to also have lower heart rate. But obviously, first thing you want to think about is the animal too deep? Did we give too much of actually like drugs? Uh, Again, as I said, we are not really that worried if we are using isoflurane or the sevoflurane or even halotane. Why? Because then we can very easily control and actually lighten the patient. But it could be a different thing if you actually like given something injectable. It's like you have to deal with it lah. I think if, let's say, those of you who are in actually like DVM3, it's like, oh, the moment you have given pentobarbital too much, you just have to deal until like the effect of the drugs actually go away. So that is the problem when using injectable and you give too much and you overdose it. So okay, if you have actually injectable that you have reversal, but many you don't have, so that is the problem. Okay, so anyway, so the steps actually like given on, the moment you actually like here on bradycardia is quickly evaluate, and also actually like look at anesthetic depth. And obviously if it's actually like just the depth and you're using anesthetic machine, very easy, just actually like reduce the vaporizer and continue to monitor closely. And then if, let's say, reducing the anesthetic machine still can't solve your problem, then you have to treat the bradycardia, and actually using anticholinergic lah, which we have here. It's actually like the atropine. The dose here is actually like there's a wide variations. I'm actually like using here. It's a low dose to begin with, and then sometimes you can start with this dose, and then if you don't see an effect, you give another dose. After like 2 minutes you don't see that, then actually like give again. Most of the time they respond, but sometimes they may not. Okay. I'm gonna go with actually something that looks a bit complicated. So this look a bit complicated, and so this is actually from the AFP, okay, from the Flying Practitioners Guidelines. So it looks complicated. So let's just try to actually like go into it, because then there were additional things that is actually like being kind of like consider here. Okay, and it may be actually applicable to you here. So let's say we talk about the cats here, and what they actually have in the algorithm here is that, again, this is talking about actually like a bradycardia in a cat, but then with, again, it's actually like no neuro issue. We are not talking about actually like increased intracranial pressure here. So this is actually normal intracranial pressure. There's no issue about neuro problem in here. So the next question to ask is, have this animal been given any alpha-2 agonists, such as xylazine, meditomidine, dexmedetomidine? So if it's yes, then really here on this we'll talk about actually like checking whether the patient is hypotensive or not. So so you like it or not is actually like, to answer that question, like whether we want to treat the bradycardia after it's been given alpha-2, really have to look at the blood pressure. So if the blood pressure is actually normal, okay, blood pressure is normal, but its heart rate is lower than 100. So according to this guide, it is advisable to actually like give the reversal. So in this case here is to say administer epipamazole. So that is the guide lah, given by the panel who wrote this actually like guide. Okay, so but if it's actually like the patient is bradycardia and at the same time is hypotensive, even though you have already received the alpha-2 agonist such as your xylazine, then it is indicated to treat it with atropine. Okay, we should actually give it with atropine or glycopyrrolate. Okay, because the pressure is low, so therefore it's safe to treat it with anticholinergic. Okay, I go on to something more simple. So let's say in this case here, if let's say it's a patient that have not been given any alpha-2 agonist, okay? So the next step here actually like talk about the rhythm. So if you talk about rhythm here, of course, then you see then you need to have ECG. Okay, but again, as I said, if let's say, the rhythm is actually normal, which is actually like uh, having said that, even though you can actually like hear, let's say you can actually get pulses and it's actually like normal, most of the time you can make a deduction that most likely the rhythm is normal lah. Okay, most likely it's sinus and it's normal. But the only conclusive way is that to have ECG, which we're going to talk about here, is very complicated. We'll talk about that later. So let's say if it's normal, then you go on to the step like what we said just now. Look at the depth. Okay, if it's actually like too deep, then we try to actually like reduce the depth and then see whether the heart rate actually like will increase. So if it increase, great. So that's solve it. But if it's not, then that's where then we will treat it with anticholinergic. Okay, so that's where it is. So but still, even though if it's actually like the animal is not too deep, and then it is just light to moderate, but it's still bradycardic, so we treat it. So then we actually have another step here to see whether like the animal respond or not to the atropine that you're given, because it's also very common for cats then that actually like we have problem of hypothermia. So if the animal is severely hypothermic, it may not respond to the atropine that you're being given. So therefore, then they have another step here. Then try to actually like rewarm the patient, get the temperature to go higher, and perhaps it can respond to the atropine that you actually give. Okay. Uh, oh, sorry. So let's actually like then look at the more complicated part in here. If let's say the cardiac rhythm is not normal, again, this is very rarely happen to you, but then they actually include it here, which is good. Then it's a good revision here. So if it is actually not normal, they put here some conditions that actually like may occur. So one is actually like which may be common if let's say like you have patient come with you with which is a block cat, FLGD have not been urinating for 3 days and been really blocked, and then and you have not actually like check it appropriately. So if they're having hyperkalemia, they can actually give you bradycardia. treatment here is actually written actually like insulin, dextrose, or calcium. Uh, Again, this is very, very, like I never seen this before, but just in case whether like you have actually heart block, like a second degree heart block, or even the third degree heart block. So if it's a second degree heart block, last last week I shared with you, then usually it can respond to atropine. So then to treat it with atropine. But third degree heart block actually talking about more serious problem related to the heart and so on. So like then to consider aborting the procedure, or here actually says that can try with things like vasoactive agents such as dopamine or epinephrine and so on, if at all possible. So those are the extra things from the guide that you can actually refer to. Okay, we move on to the next, mm, like non-normal physiologic parameters such as tachycardia here. Mm, so the tachycardia here I define as a heart rate of more than 180. Again, this is actually like a very general kind of number in here, just so that as a guide. Although in actually like in bigger animal, then the values should be actually like lower. Even in the guide, then they define for the cats that a heart rate of 180, it was defining as tachycardia. So like the threshold to say that it's a complication for cat is actually like quite low lah. We will say actually like heart rate of like more than 180 for cats is already tachycardia. It can be quite common for some of you to actually like see this. So what do we think about? Uh, so could it be light anesthesia? Then very easy to do. Then deepen the anesthesia. Uh, could it be because you have been given things like atropine, or maybe following ketamine induction, or any drugs that may have actually increased the heart rate? That's actually like kind of the checklist to go through. The part on actually like could it be the animal actually having hypotension, hypovolemia, or worse still is hypoxemia? So that it will be more difficult to deal with and really have to be addressed faster. Okay. Um, so basically here, if there's actually tachycardia, so first thing, quickly check whether the animal is getting light. If it's light, then definitely deepen it. Or in fact, actually like sometimes the heart rate is a very sensitive indicator, especially in cats, that the animal actually show appropriate depth based on depth assessment, meaning you look at the eye, look at the eyeball, look at the I mean, like there's no palpable reflex. In fact, actually like eye could be actually really in the center, showing you that animal is really deep, but then the heart rate can be on the high side, and then it's actually like a in correspond to the surgical stimulation, for example, like drilling through bones and so on. So it means that actually like in this case here, probably need more analgesia. Okay, you need more analgesia because the surgical stimulation really actually like cause increased release of like adrenaline, and can try by actually like putting up some analgesia for this cat. Okay. So but if let's say, like it is not because of that, and potentially it could be because of the blood pressure being low, of course, then to check the blood pressure. Because if let's say the blood pressure that is lower than 60, which is hypotension here, they often can accompany with actually like tachycardia. Okay. So, and that need to be addressed. Um, the one that actually like previously probably very uncommon. Nowadays, I'm not sure. Some practice actually like may, like do a lot of this heat support and so on. If you get your patient really too warm, they can also actually like show these complications like tachycardia. So that need to be checked as well. I think I've seen something like this before, where we warm up the cat or the dog too much, and they can actually like go into tachycardia. Animal always look like it's on the light plane and so on. Okay. Hypercapnia too, okay, can also, like too much accumulation of the carbon dioxide can also cause the animal to actually look like in the light plane and also in tachycardia, and the blood pressure also is on the high side. Okay, uh, okay, we go on to this. Just actually like talk about blood pressure and so on, and also heart rate. Maybe you take a quick look at these parameters on the parameter here, and maybe take a quick poll here. Do you think, like which of the parameters are abnormal?
Okay,
And
sure.
Dr. Ng,
Yeah, yeah. So right
I
now,
thought,
Dr. Chen. has a questions would like to ask you all. So basically, according to the monitor display here, so of a healthy 9-month-old Labrador for OHE. So what do you think? What is abnormal here? Steven, could you share the link?
Yep, just a moment. I share in YouTube first. Okay. The
Can
question
you
link, right?
share anything?
Yeah, the post
Mm,
questions link.
moment. Okay. It seems like no hyperlink here, but
Copy paste.
it's here.
Hmm. Okay, let me edit a bit.
Okay, I have the HTTP. Yep.
Okay. Continue. Okay, so you guys can submit your answer. Click the link to submit the answer to participate in the poll. So,
Also posting in YouTube. Moment.
yeah.
YouTube have banned. Okay, need the HTTP as well.
Never mind lah. It's okay lah.
There is
Yeah,
poll
yeah,
ongoing. Yeah.
they're
So
answering. Yeah.
let the audience answer the questions.
Okay. And then
Answering.
do I stop share so that you can share what?
Yeah,
Statistics. Yeah.
sure, definitely. I can share.
So once again, there's a question from a quiz here, like poll from Dr. Chen has set a question for you all, so you all can go to the chat box in WebEx and also the YouTube. Click on the link and open in your browser to participate in the question. So I hope this interaction will help you more about to know more about the anesthesia. Yeah.
Okay. Okay. So basically, it seems the poll is fully accepting the response here. So I will just share the screen. Sharing,
Hmm.
share, sharing. Yeah, I think you can see the. Yeah. So this is the result of the polls here. So basically 56%, okay, going 52% of the participants saying that only blood pressure is abnormal, and 40% stating that heart rate and blood pressure is abnormal, while 8% stating that both three parameters are abnormal here. Yeah.
Okay.
Thank you.
Yeah. So doctor, you can
Okay. Can see my slide? Thank you
Yes.
so much for everybody's response. It's a bit tricky on here. All right. So for sure, number three, there is actually like hypotension. Yeah, we can see that both the systolic is lower. The systolic is lower than 90, and then the mean pressure 48 definitely is actually lower than 60. The heart rate here is actually 71. So that's actually like uh, Mm, to say actually like if by definition, I mean it's a Labrador, so I wouldn't call this actually like real bradycardia. The question then to say that, but uh, could it have actually contribute to the blood pressure? Maybe, maybe, but then it's actually like not bradycardia. And then the next is actually like on the SpO2. So last week we actually like did mention on actually like SpO2. And then the definition for hypoxemia is 90, depends on actually reference again. Most people say about 92 to 93%. So, but if let's say the patient is actually like on 100% oxygen, so we really want to see the SpO2 reading higher, being actually like 95 and above. If the animal is on room air, for sure, if the SpO2 reading go down to 90, that's definitely is a hypoxemia that really warrant a quick, like support on the patient. So on this, actually, like then how do we actually like address on the hypotension? Um, So there are actually like in terms of hypertension, a number of actually like things to actually like consider. But if let's say we're talking about just a healthy OHE, and then you see this, so the first thing to take note is actually like quickly assess again on the patient, the depth and also other parameters. Um, Whether like first thing in your mind, you want to see whether like is the animal too deep or not. Um, and then if let's say the animal is deep sea, whether we can try to reduce the vaporizer setting. And if we can't, then we actually like look into actually like as you said here, then actually like on, people will consider, should you give atropine? Maybe actually like if you give atropine, the heart rate go higher. But again, as I said here, I don't define this as a bradycardia, but it is on the I mean like it's not bradycardia and it's actually like within the low limit lah. Okay, would giving atropine having higher heart rate will increase your pressure? Yes, it may be. Okay, so then would we give? So I would actually like go on this. I have to see on the actually like the patient. So if this animal is actually like on anesthetic, sorry, using oxygen and is on isoflurane, I'm not too worried on this. And again, it depends on actually like which part of the surgery are we. So if this is actually like, like after induction and it's kind of like sitting there, the trap is taking too long, and then and then the animal may have been actually like put on a higher vaporizer setting. So like we will try to actually like reduce it first before we jump in to use the atropine. But if this case here is actually like in the middle of a procedure and it's actually like during the surgery itself and it's actually showing this, I think I would use atropine because that would be actually worrisome. If let's say you are in the middle of surgery and then you have such a, I mean like it's just a borderline reading, so you'll be a bit more aggressive with that. Okay, so that would be actually like my approach. But having said that, actually like like majority, if let's say even if let's say in the early part of actually like right after induction and you have this type of reading, many times then actually like we also think about, is that possible that actually like this animal may have subclinical dehydration. So after ensuring that actually like the anesthetic is actually appropriate and so on, um and the heart rate here actually at the borderline and people may not treat the with atropine, they may actually go ahead and actually like try what we call as a fluid bolus. So the fluid bolus here is like it's actually defined as trying to give like a 15 ml per kilogram of crystalloid. Usually we will use lactated ringers, or you can actually like go with colloids if you think that actually like you need a longer action to stay in the intravascular system for so you give that over 10 to 15 minutes. So that fluid bolus will actually like if it's related to the animal having hypovolemia, it will actually help with the blood pressure and improve on the fusion as well. Okay, so if it's me, I would probably actually like after checking the depth, I'll probably actually choose the third actions. So if let's say after you have actually like tried all this and actually like the blood pressure is still not up to your optimum, then you actually like go on to the last part, which is actually using on the vasoactive drug, which is again actually like these are talking about things like ephedrine, dopamine, dobutamine. Except for ephedrine, which is easy, you just give one dose. The rest of it actually like need to go and CRI. So if your practice, like you don't have things like infusion pump or syringe pump, you don't have even BP monitor to monitor. I don't really advise you to actually like using these drugs here. Okay, so that's actually like beyond most practice. But then at least like things like atropine and fluid bolus is something which actually like can be considered for most practitioners. Okay. Um, okay. I'm kind of like go more than the time already. So that's probably just actually like a few more slides to go. Dr. Ng, can I continue?
Yes, definitely,
Yeah,
doctor. You
sure,
just
doctor.
continue.
Okay. Okay. So it's actually like here on actually like about tachypnea. Again, actually like the animal actually like breathing very fast. So when it's breathing very fast, again, same thing as well. Again, have to differentiate when the animal is really tachypneic. Is it just breathing very fast and not actually like dyspnea, which is actually respiratory distress? And therefore, like that's why actually like most patients, whenever under GA, we always actually like have thought, put the tongue out so that you can see the color and like can appreciate if the animal show any like cyanotic color, that tell actually like it need immediate attention. Okay, so differentiating from that. uh if it's actually like not, then you can take your time. It's pink and good, then actually like again same thing. First thing come to mind is actually, is the animal getting light? It is actually like not deep enough. Another thing is actually like, if it's actually deep enough, then the next thing is actually like see possibility that why is the animal accumulating carbon dioxide, so you're having hypercapnia. uh Okay, I just kind of like on this here, have revising on actually last week. Somebody asked things like okay, because actually like hypercapnia, in the last part of it, actually like if it's really like you rule out everything, then the only way is actually like to assist with the ventilation, whereby when you assist ventilation, you may actually like choose mechanical ventilation, which is using a ventilator, so that definitely will actually ventilate. So the question here asks, do we typically use muscle relaxant? Actually, the answer is in small animal, no, you don't really actually like typically use it. Why? Because you have to be trained to actually use muscle relaxant. You must know that actually like if you are using it, you have to monitor, because it is blocking on the neuromuscular junction. And if you have not actually like monitor it, you may have complication whereby if let's say there's still residual effect of this blockade, then we may come into problem like animal not breathing adequately following extubation. So we need to actually like monitor well. Mechanical ventilation, one thing is, as long as we address like the animal is in adequate depth and actually bring the CO2 to the acceptable, the animal will not breathe and will not fight the ventilator. So it's quite easy to like give assist the mechanical ventilation without using muscle relaxant. And then you say, is mechanical ventilation beneficial when it seems actually like hypoventilation? And then based on what kind of parameters, and then how do we reduce the end tidal CO2? I'm just kind of like address this based on actually like the next scenario I see in here, following again a algorithm. For example, if we see things like just now what we're saying, actually like rapid shallow breathing, but again, this patient is not cyanotic, but in fact, if you look at the mucous membrane, it's actually like ejected. It look actually like break red and so on. So if you actually see that, you suspect that there's hypercapnia. So what do you do is quickly actually manually squeeze the bag so that you can actually like feel, is there any resistance in the airway? Look at how the chest is rising, trying to actually like see, like any obstruction or not along the large airway and also the lower airway. And then make sure that is the animal actually like in appropriate depth, or is it too deep or not. Again, checking through as we're actually doing that, also looking at the vaporizer setting, and thinking through what are the drugs that's been actually like given. And then of course, then while checking on that, then the next thing that come to mind then is actually like, especially if you have hypercapnia, then to look into what are is there any machine problem? Like for example, the CO2 has been exhausted. And this one here, sticky valve here, this refer here to the unidirectional valve, that the valve is not function properly, or some very old machines, or actually like there were dirt and so on the unidirectional valve. So sometimes the valve actually like gets stuck onto the opening kind of like position, and therefore you have no actually like like one way circulation of your rebreathing system, and therefore you have a lot of rebreathing of carbon dioxide, and therefore your carbon dioxide in the system can go very high. Okay, so that's actually like where you're troubleshooting what could have caused the hypercapnia. Okay, other than thinking that actually like it is the problem of elimination, then if let's say it is actually none of those problems, this another possibility is actually very low. For example, like could it possibility that the patient is actually like increasing production of CO2. So this is very rare, especially in our animals. I don't think we have seen MH here stands for malignant hyperthermia. We may actually see it maybe in pigs. Human actually like do say that, and then you have certain genes that actually like predisposed to that. But I've not really actually like seen that. Maybe in pigs we have seen that. Okay. So if you have ruled out all those problems related to the machines and actually like not underlying problem with the airway and with the respiratory tract, and therefore then maybe the animal is actually like it's actually like too deep and actually like not breathing I mean ventilating the CO2 adequate. So then so going into the mechanical ventilation will definitely help lah. So, but again, actually, like as mentioned in here, it is not common in young and healthy, but maybe in a very old animal, it may actually need that. Based on go back to the question of actually saying, so if you do have a capnography to monitor, so the value here actually like usually talk about if you have like a end tidal CO2 that is higher than 60. Okay, so other than that, it's like 50 something and so it can be quite common and so may not warrant actually like going to mechanical. You try to adjust on the anesthetic depth. Okay, apnea. So apnea, if let's say animal actually like stop breathing again, actually like if again whether like is it actually like emergency that is actually like an impending cardiac arrest, so therefore immediately check again color of the mucous membrane. So again, if it's actually like pink, not so bad yet, but then again quickly actually like check again, because if let's say mucous membrane is pale cyanotic, or like just now was apnea was a sudden change in the respiratory rate or depth, or if you look at the sign whether it's too deep, suddenly too deep, so that can be actually a suggestion that maybe animal may be going to cardiac arrest. So quickly check whether like all the pulses are okay, BP, how any irregular pulses and all that. If like all these actually like showing that the animal may be actually going to crisis lah. So therefore it actually warrant quick action on that. But there are some circumstances we may see apnea quite common and maybe actually like related to something that we may have done. For example, a very common one that we have seen is following a bolus of, it could be anesthetic, it could be actually even things like analgesia, like your opioid that you actually like suddenly give and the animal suddenly go too deep, or immediately after induction, we give boluses of actually like propofol and the animal actually like go into apnea. So therefore, when we actually like check if the heart rate, I mean like there's still pulse, is still strong, color is good, so that's actually not such a big deal. Usually it will just like let the anesthetic actually like redistribute and get lower, and then the animal will be able to actually like breathe. Prolonged bagging, or if you actually like put the animal on the ventilator and you have been actually like over ventilate the animal, and therefore you get the CO2 to be low, and the animal also will not breathe on you. So in these circumstances here, it's not too big deal, but then it's very important to actually like note that it's still not normal, but at least the urgency is not there. And then as I said here, like IV bolus propofol, immediately when we connect to the machine and the animal actually like don't breathe, but it doesn't actually like look too deep, so we can actually like, if the animal don't breathe, then just give it one breath every 1 minute, give 1 to 2 breaths, so that we get the CO2 to actually build up, and then when the animal lighten, you can start breathing again. The one more like something that really need urgent and to actually like troubleshoot if the animal is actually like really showing cyanosis, or even if let's say the pulse oximetry is telling you that it is having a very low reading. So of course immediately is to always check the patient and verify that yes, it corresponds to your pulse oximetry reading. Immediately is to check whether like how's the pulse feel, is there a heart rate, and if let's say confirm there's no heart rate, obviously then like it's time to actually like quickly jump on into CPR. And then it's the same actually, like therefore you want to actually like again give a manual bag, and therefore try to look out for actually like any problem with the airway and also the lower respiratory system. So if you're actually looking, like checking is there any sounds that actually like suggest that could be airway obstruction, as you actually like squeezing the bag, any resistance in there. And then if it's actually no resistance, then actually like then your stethoscope to listen to the lower airway, any crackles, wheezes, possible of broncho constriction, or no sound at all, suggesting that could be pneumothorax. So, so to troubleshoot quickly on actually like problem related to that. Now, if let's say that is not done, that's great. Then it's actually like like confirming, then looking into your machines and actually looking at any connections. Uh, your airway, is your tube still in? Did it actually like get actually like move a bit? Is that disconnection? Is there any delivery of actually hypoxic mixture and so on? So verify that actually like really oxygen is getting to the patient. So if that's everything you think it is, so then the last part is actually like again check on your SpO2 probe. So like if you see a lot of time, sometimes I mean like the SpO2 may not give you reading. So therefore we always actually like have to tell students to actually like correlate it and check on the mucous membrane again. Does it correlate? Okay. SpO2 less than 90 percent. Sometimes to the untrained, they may not be able to appreciate, especially if you have anemic patient, you will actually like be missed out on that because anemic patient, they look so pale. So, and they could be hypoxemia, and based on our bare eye, we cannot see. So if you have actually like readjust your probe accordingly, and then it still give you a low reading, please do not disregard the reading. The reading can be real, and therefore we have to actually troubleshoot and see why is it giving us the low reading, where is the problem. So things related to here we can still actually kind of like like try to solve it. But when it actually like go up to if the animal do have underlying problem, so it will be difficult. But again, if let's say you do have obstruction, for example, I think actually like for the past 2 weeks, we have actually like cats that they do have actually like underlying FURD. So, and then like their airway is reactive, they probably also have actually pneumonia. So when you actually like intubate, sometimes some of these actually like patient just go into hypoxemia because the whole tube is all filled up with their discharge, or even actually like filled up with pus and phlegm. So and that actually like block up the airway. So for that you have actually like no choice but to actually change, get like take out the tube and then put in a new one. Especially if you have the tubes that's actually too small and it's actually filled up or with this discharge. So therefore that need to be actually like corrected fast. Okay. I think I've actually like mentioned this before. I mean, like, so basically it's again an actually like problem, possible causes of actually like cyanosis. Quickly troubleshoot on your equipments, any airway or respiratory or even heart disease. And the animal, if it's too deep, obviously then actually like overdose, that like to try to actually like overcome, then again with gas easy, but if it's not, then will be difficult. Okay, I won't go into this on the CPR algorithm. I just want to actually share with you. You can actually like find this if you actually like type things like the Recover Initiative. You get into the website, and then they have actually like free access that you can actually look at all the various algorithm they have. It's actually in the paper itself. They will direct you to the journal paper that you can actually download and read up. Okay. So, in short, so what I'm trying to say here is actually important to get ourselves trained, also our nurse to actually like be trained. Especially can simulate like complications and see how the staff will be able to respond and actually like train. Especially if you do have actually anesthetic machine, train with how to use the anesthetic machine. And importance to actually like continuously monitor the patient right from pre-anesthesia until recovery. And the part on the recovery, I think I have to put a note here that it's important, at least like to ensure that the animal can protect its airway, that can at least like lift up its head before, like we definitely leave it without any supervision. So that's actually like again, as the paper that has been shared. So like more than actually like a majority of the complications and or the mortality, if it happened maybe within the first 3 hours post-op, and it's actually due to lack of monitoring during the recovery. Okay. So these are actually the resources that if you type in this, you would actually like get the guidelines that's available online. Okay. So with that, I thank you very much for your attention. I pass it back to you, Dr. Ng.
Yeah, thank you so much, Dr. Chen. Thank you so much for your insightful and informative talk on possible complications encountered by vets in managing the anesthesia. So, right before we move on to our Q&A sessions here, So we would like to briefly introduce the current anesthetic agent my webcast Sandra Berha bring is the isoflurane from Vet Pharma, manufactured in Spain. So just some brief information about Vet Pharma. They are an animal health solution provider which is specialized in the development, registration, and commercializations of those veterinary product, active pharmaceutical ingredients, and nutraceutical for animals. So their finished product can claim as a best quality. So manufacturer in Europe and according to good manufacturing practice and also distribute following good GTP, I mean good distribution practice here. So the product we have here is isoflurane from Red Pharma, 1000 mg per gram inhalation vapor in liquid form. So as you know, isoflurane is used for induction and maintenance of general anesthesia in animals for use in dogs, cats, ornamental birds, and other kinds of animal here. So this veterinary product here, isoflurane, we already register it with MOH Malaysia with the registration number provided below. So of course you can search for our product in the Crash 3 Plus product search by MOH. So by searching using product name, key in isoflurane in the Crash 3 Plus product search, and you could find that the registration number and also product that bring by us, my webcast and Berhad. So you do not worry by using illegal, but this one is registered product from us. Okay, so right now we're moving on to the Q&A sessions here. So if you have any question, you can type in the chat box. Then we will try to read out to Dr. Chan and she will answer it. So okay, so for those who at YouTube channel, you can also type in your question on the chat box in YouTube. Then we will read out your question accordingly also. Mm. So right now we are waiting some question.
We are waiting, right? Actually, I prepared some slide to answer.
Sure.
So I'll just actually go ahead and actually like share. So
uh,
a question talking about emergency. I maybe it's emergency drug that is actually like asking. But actually like just to actually like answer on this, then when I actually go to the AVA checklist, so they kind of like actually like say if you are going to do anesthesia in clinic, please answer this question. For example, do I have everything required to ensure tracheal intubation? 2, do I have enough oxygen and is the equipment ready to deliver? 3, can I immediately perform manual IPPV? 4, can I administer straightforward IV drugs or fluids, i.e., is the IV catheter in place and functional? If not, is everything ready to gain IV access after induction? And 5, is a CPR procedure in place and are the emergency drugs available? So actually, like in accordance to things, then if you actually like look at again, you can actually find this under the recover initiative, and you see actually like in terms when you need to go into advanced life support and see what are the drugs that's been listed in here. So I just actually make it short. So basically, if you are using drugs, then have to ask yourself, especially like let's say xylazine, do we have the antidote or the reversal? Um, the other thing that if you look through, then you have things that listed like atropine, adrenaline, lidocaine, bicarbonate. I add on another one which is actually like the glucose lah, because we actually like do see that actually like some animal uh come into like hypoglycemia and they don't do well, and then when you check the glucose is hypoglycemia, and then glucose will really solve that problem. So that's also like consider emergency should be available in your clinic. Then the rest of these are things that is actually as asked in there that you're able to actually like do. So this thing would enable you to address actually like emergency. Okay. uh then there's also this question like likely a young cat being choked by own saliva during recovery. Actually, it's quite, not to say it's quite common. It can happen. And so therefore, for me, I like to have my animal actually recover on put him actually like even though it's not fully recover, I try to actually like possible. I like my animal to recover on sternal wherever possible, or actually like if see lateral, or more importantly is actually like there always a chance that actually like there will be continuously actually like production possible of saliva or anything like that, or actually like I have seen a couple of pets following ketamine xylazine. I mean, it's very rare, but it still have happened before, and they continue to regurg or even vomit during the recovery. So, like it's if you actually like place in such position, or even actually like maintain the pharynx is higher than here, so things that actually like being come out can drool down, and so therefore we prevent again complications. Pre-oxygenation, is it necessary? Uh, in all animal, not really. So if it's actually like anything that if you think that is you take time for you to intubate or actually get the airway access so that you want to prevent hypoxemia, yes, then go ahead with pre-oxygenation without stressing the animals. So that's very important. So I think in most geriatric or obese or cardiopulmonary or critical ill patient, for sure, actually like try to put in a protocol whereby you can actually get the animal sedated so that it can tolerate the oxygen mask for 5 minutes, okay, before you induce. And one thing I want to say about pre-oxygenation, which again I find people may have done things wrong, is that pre-oxygenation means actually like having like the mask doesn't have to be fitting. It can just actually like giving supplemental oxygen. So the animal is just breathing in higher concentration oxygen. The purpose is to fill up the whole airway, try to increase the airway FiO2 to close to 80, 90, even 100% if at all possible. So that's why we need actually like 5 minutes to actually get the high. And then the mistake that most people done is actually like just you about to induce, you remove the mask. No, you don't do that. You continue actually like the mask should be there while you induce the animal. So as you actually give the induction agent, then animal actually like go get induced, and once it's actually induced and it's deemed that you can actually like check able to intubate, then you remove the mask and therefore you do the intubation. That is the proper way to do the pre-oxygenation. And then the other point here, based on the AFAP guide, because I guess most cats, people find it actually like may have difficulty and you may take more time to intubate, and therefore in the guide, it actually says that you should pre-oxygenate the cat. But you have to think about it that actually when you pre-oxygenate the cat, the cat shouldn't be actually like struggling with you for your pre-oxygenation. So, like good sedation for you to able to carry out this pre-oxygenation is very important. Okay. I stop here for a short while. Maybe Dr. Ng already got some questions.
Yeah, we have about 4 questions. I'm not sure if
Okay.
Dr. Ng and Dr. Chen can see from the Q&A. So I have pasted the first question from Joshua Tay into the chat box lah.
Let me stop share and
So
maybe
Dr.
I
Ng, you
can
can, yeah.
can't see anything on the chat.
Right, no worry. Dr. Ng will. Hey, Dr. Ng, your mic not.
I will read out the question for you, okay, doctor?
Okay, yeah.
So basically, we have a question from Dr. Joshua Tay asking that Dr. Chan, during the cesarean pyometra surgery, which is induced with TKX and maintained on isofurin, the animal tends to have a transient apnea upon the removal of the uterus from the abdominal cavity. It's around like 15 to 30 minutes into the surgery. So during the process of removing the uterus, we practice a 10 to 15 minute shock rate of lactated ringer, and also the pulse oximeter showing normal, no BP monitor. Can you comment on this? Basically, I
Um, I think very hard to actually like comment because there's no BP monitor.
Mm.
Uh, 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 the part on actually like whereby you are anticipating that the blood pressure probably would drop when you actually like remove the pyometra. So which actually like we do actually like see it, especially if you have really like the uterus is so big, and we do see actually drop in the blood pressure. So giving LRS actually like at a shock rate at you mentioned that is actually like about 15 to 20 minutes, right? So I guess that is just actually like correspond to a fluid bolus. So of 15 to 20 minutes, and I think that should be acceptable lah on that. Having said that though, it may actually like varies depending on actually like how sick is the dog. Meaning actually like I think you should check on actually like if you at all possible probably should actually look into the total protein of the dog just to actually like ensure that actually like it's not too having hypoprotein if you can. Uh, but I suppose it's actually if you say just for 15-20 minutes with the short rate usually should be okay to me lah. Okay, yeah. The part on actually like they you actually notice the animal go into apnea is quite interesting because I can't I mean like I can't actually like figure out why actually like it would be breathing fine but then after that then only after the removal of the pyometra that you go into apnea. Could it be actually like corresponding to actually animal also at the same time become too deep and like even without any change then it's suggesting that the animal is probably going to shock and therefore actually like give you that. So if you find that actually like giving the fluids actually like does reverse it, then you are doing the right thing lah. Yeah, thank you.
Okay, thank you, Dr. Chen. So we have another question here is from the name I couldn't. So it's okay. So it's questions saying that asking that. So basically, they are shifting away from using TKX, which including the xylazine, due to difficulty of recording to fulfill IPRA, and also using. So she asking that whether using either standalone of Zolotil or Propofol, will there be a difference in term of welfare for patients under anesthesia?
Uh, sorry, I'm catching in here is actually like if
Is
using Zolotil alone or using Propofol
Propofol?
alone,
Mm,
is there a problem with the welfare?
mm,
Um, I, I'm trying to actually like catch here what he's trying to say here. Are we actually
mm,
saying that is it okay just to use a anesthesia protocol of just using propofol alone? Depends on what you're doing. I mean, I guess like in terms of actually like what we're advocating on the balanced anesthesia, if you are doing uh, surgery and therefore will accompany with actually like pain, so for sure need to address the post-operative pain. Perhaps like in terms of actually like safety, you can't incorporate that because you have no monitor at all intraoperatively, but definitely have to address that in your post-op. Like some whether it's actually like at least a non-steroidal to address on the analgesic if you're talking on that part. But then having said that, um, uh, that means actually to recognize that both propofol and Zolotil on its own, these are actually anesthetic lah. So I mean like for fraud procedure, people have been using propofol. I mean like and then even used as a total intravenous anesthetic agent. Yeah, propofol has been actually used. But if you say that again, you have to add on like analgesia if let's say you are doing surgery. So that probably can address on the animal welfare I would think. But having said that, again, your choices of able to actually maintain with just this is you have to choose the patient appropriately as well. Uh, because then, to get the animal into the state that you want, and if it's actually like a high risk patient, like you can't just actually like totally depend on just propofol alone or Zolotil alone lah, I guess. But if you're actually like talking about just castration or overall hysterectomy, I guess it can be done just after that for the post-op address the analgesia. That's I can think of. Yeah, that's the
Yeah.
answer.
yeah, thank you,
Thank
Dr.
you.
Chen. So
Yes.
I think we have another three more questions here lah.
Yeah, so
So
I will share the question, Dr. Ng, in Microsoft Word so Dr. Chen can see through the screen.
okay, so
Mm.
before that, just saying that
Can you
yeah, we
see
have
my
a
screen?
questions from Dr. Liang Vivian. So how can I ensure the rate of pressure so that I'm not hyperventilate? Uh, hyperventilate your mouse. Hyperventilate or overbagging the animal when they have apnea or low oxygen saturation.
How can I ensure the rate or pressure so that I'm not okay? So I suppose here, uh, obviously, of course, we actually like we are not talking about mechanical ventilation here, but we are actually like just talking about I presume here there's no monitor. Um, like your rate and pressure, and you're doing actually like manual ventilation. Um, okay. If you have actually like the anesthetic machine, so we're talking about here, if you have the what we call that as the rebreathing system, and it's connected to the manometer, then we use the manometer and actually like look at the manometer is the book will says that actually like don't go beyond 20 centimeter water. So like, so ideally is to have that the manometer to actually like guide you in your actually like in your doing your, I mean, like assisted ventilation. And the rate is, so I would actually like say something like this, because if I based on my experience of using mechanical ventilation, so if I set the ventilator, if I'm actually like doing like 10 to 12 breaths a minute, so meaning actually like one breath every 5 to 6 seconds, and then the pressure that I'm creating is between 10 to 12 centimeter water. Most of the time, I can, if I got another monitor, which is the capnography, I would be able to actually like achieve quite a good reading, which is actually like between 35 to 45 millimeter mercury, like I target usually with this in majority of case. But of course, in some case, actually like it is not. So therefore, what would be the chance that if you keep bagging and then you may overventilate? Yes, that could be the problem when you overventilate, and you get the SpO2 to be actually like too low. So if you are to actually like have a guide on actually how to do it, I would actually I say that try to get hold of a machine that you have a manometer, and therefore practice on the typical, like a animal with the size animal. And therefore, when you're actually ventilating, you look at actually like when you're ventilating and creating a 10 centimeter water, how is the chest excursion? I mean, how is the chest moving and expanding? So you actually like see that, so that then you will not over ventilate. Okay. Um, that is actually like my advice I can actually like give lah. So it can be actually like difficult, especially if you're talking about cats, because then most of our system here are using like modified Jackson Rees, and therefore it doesn't have the manometer. So if you actually like ask, the best way is actually like you try this, and if you do get access to manometer and also even the capnography, so when you're actually like trying that, and you are able to actually like see what you are creating when you're actually doing that. But again, it's just actually like a very crude way of actually like try to estimate. Of course, ideally is to have the monitor to for sure tell you how is it. Yeah. Okay. Uh, hope that actually like answer.
Okay, so I think due to the time, we will be answering the last two questions here. So the fourth question will be from YouTube from Dr. Nadia. So Dr. Chen, what can we do when the animal has been tachycardiac for the past 10 minutes, even on the maximum vaporizer setting? The animal is still in deep anesthesia plane.
Oh, okay. So this one here actually like go to the tachycardia slide we see just now. So in this case here is already in deep. It is actually deep. It's not actually in light plane. So and then we have to actually like see. So just now we said we go through on actually like first is actually like, could the animal be hypotensive? Accordingly, again here is actually like we hope that the animal is also not hypoxemic, not hyper capnic. So if it's actually hypotensive, then actually like then we have to treat this lah. So these are the more kind of like honestly, without the monitor, it's very difficult to actually like troubleshoot. But first thing is actually like to see that actually like animal is in deep plane, mean actually like the respiration is okay, but then the heart rate is actually like still on the higher side. So then we have to see that actually mucous membrane, have to actually like see if the mucous membrane is actually not hypoxemic, but instead is actually like very ejected, look very like we call it ejected, means actually vasodilation. So if let's say hyper capnia is actually like could be in there, then you address the hypercapnia by actually like assisting with the ventilation. But if let's say, like it's tachycardic and then you correspond and see that, well, the blood pressure is actually like low, if you don't have the BP monitor, again, it's very difficult, but maybe correspond by actually like seeing is your CRT actually like adequate? Is it actually like 2 or is it prolonged? So if that's what it is, then if you think there is hypotension, then address the hypotension. Yeah. So maximum vaporizer setting. Okay. It's very dangerous then actually like when you say the animal is on a maximum vaporizer setting, it's actually like usually if we go on to even isoflurane for 5%, we usually cannot go for too long. Even after 5% for actually like in a minute, you really have to actually like go lower. And if you say that actually like at like if you actually need to put it at 5% for 2-3 minutes and the heart rate is still not coming down, then obviously there's something very wrong with the with your case lah. Something else is actually like not talking about actually like the anesthetic depth, so it's some underlying problem that need to be addressed. Okay.
Okay, so we have a last question here. So we lost a British bull 72 hours after a procedure under anesthesia, which we suspected due to the trachea collapse. It is possible something went wrong during the sedations or anything we could take note to avoid this kind of incident happen again.
Suspected due to trachea collapse. Trachea collapse in this case here means actually like the animal was already showing sign of trachea collapse. So basically it should be actually like having like all those signs, honking sound and coughing and all that thing. So is it possible something went wrong during the sedation? I actually like honestly don't see the whole picture here, so it's very hard for me to actually like just comment in here, because if you see that it's actually like it died due to trachea collapse, it means that it might have actually like it's a disease that actually like, you mean, are you saying that you already have that and perhaps then actually like worsen because of the anesthesia? I don't think anesthesia can cause the trachea collapse, because trachea collapse is a disease that actually like grow over time and it actually can worsen. Although having said that, if let's say the animal gets stressed and the more he cough, the more get stress he is, the trachea collapse actually like can really collapse and animal can die of it lah. But if you actually like say that actually like anesthesia or your sedation cause it, uh, uh, I mean, I can't really actually get what it is. So meaning actually, if the animal do come with trachea collapse, uh, if it's actually kind of like something wrong with the sedation, how is it that actually like something wrong with sedation? Basically, if it's a trachea collapse, then obviously we want to reduce the stress. But if you are suggesting that it's because you stress the animal so much that actually like it dies 72 hours because of trachea collapse, sorry, I can't see the connection in here. Apology. So maybe actually like if I don't answer this well, whoever asked this question can maybe email me, then we can actually like talk further to understand. Because to me, it's actually trachea collapse is the disease that it already been there. Could it be possibly that actually like more stress actually worsen the trachea collapse is possible, but if it anything happened, it actually should have you should have seen it actually like if you're asking about during the sedation, then it should be actually during the sedation, you see the animal actually like collapsing and the collapse is actually like collapsing in there. So, like to say that actually like the sedation caused it, I don't think so in that way. Yeah.
Okay.
Yeah.
Thank you so much, Dr. Chen. So, Dr. Chen, do you have some more to present from your side, or we can just end the Q&A sessions now?
Yeah, because
Okay.
actually like talking about the hypercapnia situation. So those who are interested, let's stay on since I already like prepared the slides.
Sure.
Okay. Let's see.
Maybe we send in the attendance link for those who want to leave early, then they can click the link, and those who want to stay, then we can go along with Dr. Chen's slide.
Yeah, it's just actually like addressing like two questions, I guess.
Okay.
Can you see my
Read the
slide?
form. Yes.
Yeah, okay. I just want to read here because I see that there's somebody who say always have cases of apnea after prolonged usage of isoflurane and prolonged mechanical ventilation. Is there any chance to reduce the apnea problem? So when I read this, I guess it's actually kind of like so the animal is on isoflurane and this animal is also on put on the mechanical ventilation. And then when you want to take off the mechanical ventilation, the animal like is in apnea. So for sure, if actually like if the animal is still in the deep plane or anesthesia plane, like surgical plane lah, and then if your mechanical ventilation you did not actually like measure your end tidal CO2 and you get your CO2 to be actually like too low, so there's no motivation for the animal to breathe. So of course the animal will not breathe. So when we want to actually like wean the animal off the mechanical ventilation, there are a few ways of actually like doing it. Of course, one is actually kind of like the moment you off the mechanical ventilator, and then you just wait lah for the animal to breathe. But every 1 minute, every 1 minute, if the animal don't breathe, you actually give 1 or 2 breaths. So you support it. So in doing that way, what you're trying to get is actually get the animal to build up its carbon dioxide so that he start breathing. And this can only be done if the animal is actually like not too deep, meaning it have to be either surgical going into light plane, then its sensitivity to the increase in the carbon dioxide will actually like improve. So that's the way you actually like wean off lah. Uh, yeah. And another way that actually like somebody do is sometimes before they wean off the mechanical ventilation, so you will actually like either reduce the tidal volume or don't do anything with the tidal volume, reduce the frequency so that then again you actually get the carbon dioxide to actually increase, then only you actually like remove the ventilator, then you will actually start breathing. So either way is fine as long as you understand that you need to get the carbon dioxide to build up so that then the animal will have the drive to breathe. Okay, at the plane light enough for it to actually like breathe lah. Okay. This one here, this one is actually like hypocapnia situation is increased oxygen supply help? If yet, what's the level? Okay, I want to actually like address this because then again, I come out again, this look very complicated algorithm again is actually from the AFFP. So, but just in short to actually like come into here, if you see this one on ventilation, so one part in here that's talking about if you over ventilate, so you get your end tidal CO2 to be too low, and then this one here is actually like not adequate, and therefore if you can measure end tidal is actually too much. Or the other one here is actually like you have rebreathing of like carbon dioxide. So when you ask about the thing on the oxygen here, I assume again that actually like this is using on is on actually like oxygen, meaning using the anesthetic machine. So if you actually like look into all this in here, um, the oxygen may help, may not necessarily be oxygen. Okay, so if you're actually like talking about you have like rebreathing of carbon dioxide. Okay, I just make this actually like bigger. So if you have rebreathing of carbon dioxide, so maybe your oxygen flow rate is not adequate. Okay, maybe there will also like increase in the dead space, and so there is actually rebreathing of carbon dioxide. So in those situations, maybe increasing your carrier gas or your oxygen flow rate will help. But this is talking about if you are rebreathing carbon dioxide. Okay, not actually like what we say that is actually like too much of actually like hypercapnia. So we actually have to go back to the algorithm hypercapnia, have to troubleshoot other things. Okay, the other things that talking about hypercapnia is all here lah, related to your anesthetic depth, the patient itself, any problem with the airway and also the respiratory tract, and all those things need to be actually troubleshoot according to the algorithm. Okay, so I guess that's it that I want to address. Okay.
Okay, thank you so much. So right now I'll be sharing screen here. We'll be providing you the